Welcome to the body imaging cases. This is a case of a 32-year-old male with chronic renal failure on hemodialysis and incidentally seen focal liver lesion on ultrasonography. On ultrasonography, the liver was fatty and therefore focal parenchymal fatty sparing was considered among the differential diagnoses of the focal liver lesion. CT was performed without intravenous contrast agent because of the renal failure. The arrow points to the site of the lesion, as we will know from subsequent imaging studies, but the finding against the fatty liver, which was seen on ultrasonography, was that the Hounsfield unit value of the liver parenchyma has been 54 Hounsfield units. What to do next? The nephrologist refrained from doing gadolinium-enhanced MRI, so it was decided that PET-CT may be a good way to know if we are having significant focal liver lesions or not. PET-CT showed intense FDG uptake at the lesion seen on the ultrasonography, and the possibility of metastasis has been raised. Full investigations in search of a primary neoplasm failed to demonstrate any, and the nephrologist finally agreed to do MRI of the liver. The lesion was entirely iso-intense on T2 weighted images. On the out-of-phase and in-phase T1 weighted gradient echo images, there has been a little drop in the signal intensity of the liver on the out-of-phase images compared to the corresponding in-phase images, but this drop of signal was enough to show that this part of the liver, the site of the suspected focal liver lesion, has not shown signal drop, a feature which suggests focal parenchymal sparing in fatty liver, particularly that the site of the lesion is entirely iso-intense on T2 weighted images and on in-phase T1 weighted images. Dynamic gadolinium enhanced MRI showed also features which suggest that this is not a true liver lesion but a rather focal parenchymal sparing in fatty liver. We see here a very subtle enhancement of the lesion which equilibrates on the delayed images. So the assumption of focal parenchymal fatty sparing was very strong, supported by ultrasonography and by MRI, but there have been also three major objections to this diagnosis. First, if this is focal sparing in fatty liver, why was the drop of signal on the out-of-phase image so mild? We have here a drop from 180 to 161. This is something like 10% drop in signal intensity. The second objection, if this liver is fatty, why is it measuring 54 Hounsfield unit on unenhanced CT? Third objection, is it possible for focal sparing in fatty liver to have such an intense uptake of FDG on PET-CT? Let us think of these objections one by one. If this is focal sparing in fatty liver, why was the drop of signal so mild? Let us consider these two different patients. Patient 1 is a typical case of fatty liver, and here you see drop of signal intensity on the out-of-phase images compared to the in-phase image. Patient 2 is a patient with hepatic iron overload, and here you see the opposite. Drop of signal on the in-phase images compared to the out-of-phase images, not because they are in phase, but because they are having higher TE than the out-of-phase images. Now, suppose we have iron overload and fatty liver within the same patient. The fatty liver will decrease the signal intensity on the out-of-phase images, and the iron overload will decrease it on the in-phase images. And this is probably what happened here in our patient. This liver is assumed to have iron overload and fatty liver. The fatty liver was obvious enough to show the focal parenchymal sparing, and the iron overload is responsible for the drop of signal in the in-phase images, which makes the difference in signal intensity between the two very mild. A very important remark to make here is the low signal intensity of the liver on the in-phase images in our patient compared to muscles. Normally, the liver has higher signal intensity compared to the muscles, and this is very obvious here in the example of the in-phase image in the fatty liver. Now, if this liver is fatty, why is it measuring 54 Hounsfield unit on an enhanced CT? This is a scale of the Hounsfield unit, and I have marked here the 30 Hounsfield unit threshold and the 60. Below 30 Hounsfield unit, the liver is fatty. And above 60, it is a dense liver, which happens in iron overload and amiodarone toxicity, to name only two disease entities. So between 30 and 60, we have the normal liver, but also we have the combined fatty liver and iron overload. And this is exactly what may be assumed to have happened in the present case. This is the diffusion weighted image in our patient, and in fact it has clinched the diagnosis. Based on this image, we can conclude that we are dealing with combined fatty liver and iron overload. Someone may object, saying, how can such ugly and technically poor images be useful for diagnosis? The answer is that these are not ugly images and they are not technically poor. If you look at the abdominal and thoracic wall, if you look at the stomach, the signal intensity is perfect. If you look at the splenic flexure of the colon, the signal intensity is good. The spinal cord is perfect. What is missing is the signal intensity of the spleen, which is usually very bright on the diffusion weighted images, and that of the liver. And this is because the liver and spleen are having iron overload, and these echoplanar diffusion weighted images are very highly sensitive to susceptibility effect caused by the iron in these two organs. So this proves the iron overload, in fact, and it shows also the site of the lesion here, which is devoid of any signal. And this reassures everyone that we are not dealing with metastasis, because metastasis in a liver which is fatty or showing iron overload will not share the fatty content or the iron content. So they would have been seen normally as the stomach is seen in these diffusion weighted images, and will have their usual diffusion restriction as metastasis. The third question, or the third objection, is probably the easiest to answer. Is it possible for focal sparing in fatty liver to have such an intense uptake of FDG on PET-CT? The answer is yes, and it is easy because it is supplied from the literature. You have tens of case reports describing how focal fatty sparing may have intense uptake of FDG and therefore may be mistaken for malignant neoplasm. Everyone was happy with the diagnosis, and the lesion which was seen on the PET-CT was not even biopsied, and the patient received a transplanted kidney, actually from his own father, illegitimate inheritance. This is his ultrasonography 7 years after the images we have just seen. And the settled diagnosis here is a combined hepatic iron overload and fatty liver with focal parenchymal sparing. We learned that focal parenchymal sparing in fatty liver may show uptake of FDG on PET-CT, not to be mistaken for metastasis. The explanation is that this is the part of the liver which is most metabolically active, because the rest of the liver is affected by its fatty content. Iron overload of the liver appears as drop of signal intensity of the liver on the in-phase T1 weighted MRI compared to the corresponding out-of-phase MRI. Not because that is an in-phase image, but because the TE is higher on the in-phase images than in the out-of-phase images in most of the institutions. The opposite of that happens in fatty liver, but this time because this is an out-of-phase image. We learned that fatty liver and hepatic iron overload may coexist, and the diagnosis is possible on correlative imaging. The concept of correlative imaging is very important. It simply means that we take information from each imaging study and put this information together to get a sum of information which is higher than the individual components. In this particular case, if you look at the ultrasonography alone, this is a fatty liver. If you look at the CT alone, this is not a fatty liver. If you look at the diffusion weighted imaging alone, this is an iron overload. If you look at the PET-CT alone, this is malignancy. If you look at the T2 weighted images and the gadolinium enhanced MRI, you don't have any focal liver lesion whatsoever. But if you put all these things together the way we did, together with the quite interesting findings in the out-of-phase and in-phase images, where the fatty liver drops the signal on the out-of-phase and the iron overload drops it on the in-phase, adding to that the information from the literature that focal parenchymal sparing in fatty liver may show uptake of FDG on the PET-CT, then you can make the correct diagnosis and you spare the patient the trouble of the biopsy.